everyone. My name is Holly Rayner. I'm an associate professor from the University of Tennessee in Knoxville, and I'm the moderator today. What we're going to do is I'm going to have the speakers reintroduce themselves, and then we'll open it up for questions, and I'm actually going to run around and give you the microphone. So don't ask your question until you've got the microphone in your hand, please. Okay, so with that, would you go ahead and reintroduce yourself?
Absolutely. Thank you, Holly. I'm Rebecca Kelly. I serve as the Director of Health Enhancement Planning for the University of Alabama. I was the first ever Director of Health Promotion and Wellness 8 years ago at the University of Alabama. So not unique to many organizations. We do health and wellness, and I also serve as an assistant professor and get to teach. So some fun stuff.
I am Danielle Wadsworth. I'm an associate professor in the School of Kinesiology at Auburn University.
I am Melinda Valiant, and I'm at the University of Mississippi, and I'm an associate professor in nutrition, and I also work coordinating our sports nutrition services, so I'm a board-certified sports dietitian, and I get to teach some for free, too, or for fun. And so I think we'll go.
Okay, so I'm going to open it up to the audience. Who would like to ask the first question? You're a lively group. Oh, thank you, Delia. I have lots of questions for y'all.
I'm sort of interested in whether or not, if you think about employee wellness, are you looking, what's your first order priority? Taking the folks who are engaged in your program and getting them more engaged, or trying to spread the range of the people who are engaged with you? Now, I know you're going to say both, all right? But I really am interested in what are your highest priority strategies? Where do you focus the majority of your resources and your time?
So population health management versus clinical approach. I think they're all happening at the same time at universities. So you've got the clinical approach launching from the medical center, or perhaps there are other initiatives. I mean, these two have certainly very targeted interventions as well. But how we approach it is this continuum of health, which is population-based. So you want to really upwards of 80% of your employee population is already healthy. They're only spending 20% of the healthcare cost. So you want to keep the low risk low, and you do that through health promotion. So screenings, make sure they're aware of their numbers. You don't have to spend a lot of intervention time. You need to identify the 15% that are those at risk. They use tobacco, they're obese, they have prediabetes, they have prehypertension. Those are the individuals that through screening you can spend more time in terms of intervention, and that's where we'll spend more time. And then the higher risk, which are really that 5%, which spend 40% of your health care dollars. I mean, you're talking a couple of hundred employees that are spending probably 10 to 15 million, at least in some settings. That group is not one that we work with in terms of health and wellness. That is where the case management, the disease management, the partners really have to play a role, the centers of excellence. I mean, all the value-based insurance and benefit design.
I appreciate that, but I was not clear in my question, I think. And that is either from the perspective of those who are healthy and you're engaging in primary prevention, or those who are at risk and you're engaging in secondary prevention. The proportion of the folks in a work site or at the university who are actually doing what you're asking them to do is going to be less than 100%. Right? And so, in fact, I think that on some of the things that you showed, you were moving up to like maybe 26% of your folks actually engaged. So do you spend your resources in getting that 26% to do more of the recommended things, or to try to reach out to the, okay, I'm doing the math and it's the end of the day, 50, the 60+%, thank you, percent that aren't engaging in your health and wellness programs in the stratum of primary or secondary prevention?
Right. No, it's a great question. So we have upwards of 50% that participate in one or more campaigns. The 30% are those that do the health screening. They do a full 12-week program, and they get an individual or group follow-up. So they're the highly engaged. Of the highly engaged, the 30%, we had a 30% shift to improved health, which is absolutely amazing. So when you think of that, the opportunity is identify those that are already engaged and improve their health. And because you'll see in most of the populations, you might see a shift of 3% of the total population improve health over a year. So when you take 30% of the 30%, we're still at, 3 times the number who are shifting. So to answer your question, you have to do all of it, but in terms of where the focus, especially if you've got some limited resources, I would say to start with those that are engaged, because who else is going to change behavior? I mean, at the end of the day, it's not the education that moves people, it's their motivation, and that really comes through, lots of different techniques. Okay, that was mine.
I think that you have, when you're working with worksite, I think you have to take the goal of the worksite and the stakeholders into play. So if I'm a worksite person and I own my worksite, I want the highest risk targeted. And that's where I want my efforts concentrated on, because as she said, they're the ones who cost me the most money. And in doing that, so you recruit those specifically. So you have programs for individuals who are over a 35 BMI only. In targeting those. So that's my perspective, is I think you have to take the stakeholders, and for worksite, the stakeholders have to have a say. And that's the employees as well as the owners of the corporation, or however you want to play with it. So I would think that their goals are going to factor into how you utilize your resources.
And I would absolutely say that that's true. In the program that I've worked with, that's what I was told. You will target the people who have the highest number of risk factors for metabolic syndrome. And so that's what that's where we targeted. And unfortunately, sometimes those are the hardest to engage, I think. But those are also the ones that, if they do engage and participate, they show the greatest improvements. But I think that I absolutely have been in that position, because the company was paying just specifically for that. It was great that other people were engaged and participating, but that was really the focus.
And 2 other quick points. One is, in our population, 90% had 1 or more risk factors to begin with. So even when you look at who's wanting to get engaged, we had already those that were either at high risk or moderate risk. The second thing is, when you really look at your healthcare claims data, it's not your employees that are the highest cost, highest risk, it's your spouses. So one of the significant opportunities is how to engage the spouse. And that's really what we'll continue to hear about, is not just the workplace, but how to really create campaigns. They're almost 25% higher in healthcare costs, the spouses. There's the healthy worker effect. So if you've got them engaged at work, the likelihood is they're moving more because they're at work. They're probably controlled a little bit more in their eating because they don't have more time to eat all day long. They may not be going to the doctor as much, which could be a limitation, but it's also because they're at work, and if they're not at work, they're not paid. And so there obviously is that impact too.
Well, and talking about the doctors, have you ever contacted their physicians, that the high-risk population, and trying to work with them and see what you can do to work with the doctors that treat those patients? Have you ever have done so?
In our program, we have one program that's for individuals who have greater than 35% BMI, and so the comorbidities that are associated with that are tremendous. And so, yes, we do work with those physicians. And being a smaller community, most of those physicians. So we're able to do that, and for a very controlled group. I'm not sure how that works in terms of if you're in a larger city or you have a larger population. Some work sites themselves, they have physicians on staff. So, that's extremely easy. Then that general physician very well. So in that case, yes, you'd be able to do with that. But that's kind of my take on it. And physicians really don't know a whole lot about physical activity, exercise, or healthy eating. So.
Perhaps. At the university, we have amazing healthcare providers. So whether they're physicians or nurse practitioners, we have over 200 nursing students that rotate through our WellBama screening. They now have the highest score in their NCLEX in health promotion. Our nursing faculty partner with us to do the outreach as well as do the research. And then our faculty, we refer, so we actually now have a coordinated, if you're at risk, they go to the faculty staff clinic. And so they really, especially for our new faculty and staff, it's a wonderful partnership. And it's helpful for them to really start with a trusted clinician, which we know is an impact of health. I mean, if you actually can name your physician, the likelihood of you being healthier than someone who can't is great and significant. So I think that's an important, very simple opportunity is for every employee or part of your benefits is just to name who your primary care, provider is as well. We also just hosted the patient-centered medical home event on campus. We brought in several other physicians who looked at, again, what's this model of where you have a primary care home, but then they really help with all the coordination of specialists. They also are involved in the care coordination. So if you do have a chronic condition, you don't wait to reschedule an appointment. You're actually part of a routine follow-up, and if you miss your appointment, you are called. And so it's the whole care coordination. So we're seeing a lot of that. But again, at a university, we have resources that in some of the work sites that these two were talking about, they may not be able to leverage as easily.
Actually, in my work site, physicians, because we have employees that are in 9 different counties that drive in, and so they would be seeing multiple, different physicians. We actually get referrals back from the physicians. And so one of the things that is important to know about the health coaches that I had is maybe 2 out of all of those health coaches that I've utilized were registered dietitians. And so the other registered dietitian was me. And so when they got a referral that was for a specific medical nutrition therapy intervention or was outside of the scope that those health coaches could provide, either myself or we would refer to another healthcare provider. So actually the physicians for these employees would sometimes be a referral for us. But the company, GE Aviation, did hire a worksite, an on-site nurse, and she did coordinate a lot of those referrals. But getting in with the physicians has been difficult just because it's such a spread out workforce coming from multiple counties.
I would encourage all of you also to look at the Exercise is Medicine initiative, which is really nice to see a coordination in education. So we've got our faculty in kinesiology that have been meeting with our faculty in our community health sciences to explore exercise and really tobacco. So on the intake, the conversation is not just what are you here for, but I noticed that you're using tobacco. Let's talk about that. I noticed that you're not exercising. Let's talk about that too. So I think it's changing. Again, it's creating an opportunity for the engaged conversation that may not occur. But there are, at least with our health plan, they have the prescription pads. So, and the prescription pads are all connected to improvement in health that individuals can do.
With the plant at GE, are you all, is your nurse still available? Is she still part of that?
Yes, she's actually hired by GE and she's on site. She works staggered shifts so that she's available.
One of the initiatives that we're working on, and this is a statement, not a question, is a concept called shared medical appointments. And we've taken the model from Cleveland Clinic and we've applied it both to chronic disease processes as well as specific things like prostate cancer and knee replacement arthritis, but mostly it works best with metabolic syndrome and type 2 diabetes. And what happens when you put them in a shared medical appointment setting, they create their own support group. So you kind of end up with a support group of like or similar disease processes, and we think that model works quite well for behavior modification because you create accountability and you create a support group from their peers. And what we found with cancer patients is a lot of times their questions are answered by questions that are asked by others and then get answered in that group setting. And that's something that maybe we can talk about later, but that environment has worked quite well. And we feel like small group support groups, particularly with the highest risk patients, works better because you have some folks that are naturally inclined to be proactive and healthy and exercise and eat right and sleep right and not use alcohol or tobacco in excess. And then you've got those that you just can't move. It's like pushing a rope. And with those, the more support you can get, we find that the better results we have. And it's better being supported by their peers than it is by you or me or their employer, because we have alternative motives in their mind and their peers don't.
That's a good point.
Can you speak more about the concept of other family members? So that certainly has been one of the challenges with school-based interventions, and recognizing that just providing materials to take home hasn't been incredibly helpful. So what has been done in worksite wellness to involve other family members, and how has that gone? Because certainly there is this extra incentive from employers because of the insurance issue.
So a couple of ways to engage. One is through your benefit plan design. So there are organizations, we are not included in this, but in order for you to get an additional discount, for example, maybe $25 or 25% reduction in your premium each month, it's not only that you have to participate, and that could be an online health assessment, that could be a health screening, but your spouse has to. We're also seeing that with the tobacco surcharges, that if you're going to get the incentive or the benefit of having a lower premium because you don't use tobacco, it has to be you and your spouse. So those are some of the strategies. The other more programmatic are, we launched 6 years ago the Summer Family Makeover and based it on the national campaign of 5210, which is 5 fruits and vegetables, 2 or less hours of screen time, 1 hour of physical activity, and 0 sweet beverages. We roll it out as a 5-week program in the summer. We kick it off at the pool. It's lots of fun. Every weekend you have different things from kickball and indoor rock climbing to bicycling, and just really a way to engage. And who you'll see participate are really faculty who are not all there in the summer, but those that are there are looking for something to do in the summer, and that's really nice. New employees, because they're all wanting to be part of a community, so that's really great. And then you also have children who are wanting to participate, and it's amazing how children can change the behaviors of their parents. So I think the more that they become informed and educated. So we're looking at opportunities of how we can take that simple campaign and actually bring it into the schools. We did our Crimson Couch to 5K in the schools. We partnered with an elementary and middle school, and we had hundreds of again, family members. But those are, I think, the opportunities to leverage, take already existing programs and create some additional partnerships.
We've done some family-based things, as I mentioned, usually around a holiday or around a fun event, and made it encompass the family. Another thing that the local plant did was allow for employees' families and even extended families to come on campus and use the walking trail. And I'll tell you that GE Aviation, so I have a background check every year, and you go through pretty strict fingerprinting and just to access at their facility. And so for them to allow outsiders to come onto their walking track has been a big deal. So they've actually made it available so that that extended family of their employees could come and use that, and I think that's been important. We had a lot of events around the Olympics. We had the GE Olympics, and that included the family and spouses and things like that. So as much as we can, we try to include those opportunities for grandchildren and children and spouses to be able to get that information.
We're also doing a diabetes awareness night. We're trying to leverage, obviously, at the SEC, the sports. And so Anthony Grant, our basketball coach, and his wife, Chris, really wanted to connect with some health kind of topic or area. And so diabetes, so we'll actually, I think, be wearing blue that night only. But inviting in all of the employees and their family our employees who have diabetes and their family members with free tickets, doing the same thing in the community. We'll be working through the JDRF and ADA to provide a promotional code if you are aware of or know individuals who have diabetes. Because again, I think what a great opportunity to really connect with families in venues that they already are. Tailgating, health tailgating, I'd love to see. We're not doing it, but if any of you are doing it, I'd love to love to come visit.
We do not do it. I don't think anyone. It's quite the opposite.
I know Mark's not here, but he mentioned something, and I would really like to hear all of your thoughts on this. And he talked about, in this concept of translation, and we oftentimes use, this is evidence-based, et cetera. But he talked about in translation that you can't change the core components, because that's obviously the efficacious part of it. And I actually thought to myself, but do we actually know what are those efficacious components? Or what are the core components that may be driving something, so that when we move it to a different setting? So I was just curious about all of your thoughts about that.
Well, I think with his specific program, the diabetes program he was referring to as being extensively researched.
Yes, but I mean,
so-
his concept of like that intensity of contact is not that important. I actually, as a lifestyle intervention person, go, but it is. So I would actually think of that as being like a core component for efficacy. So I mean, but go ahead.
Well, I think what's a core component in one setting is not as translatable to what's a core component in another setting. And when we look at these behavioral skills and different skill sets, we need to keep in mind that, where people are on their behavior change journey, wherever that is, it's going to require different skills at different time points. And so I think you're right in that. I don't want to infer what he was referring, but his diabetes program has very specific, this is what's covered in week 1, this is what covered in week 2, and we're thinking about those theoretical constructs. And I would think that the theoretical construct does not change, but how you address that theoretical construct in different situations is going to be very different. How I address self-efficacy for a child is very different than how I would address self-efficacy for an adult. However, that core construct of self-efficacy is still there. Same thing with other skills. And so I think if you look at it from a theoretical perspective, the constructs are still there, but how they're implemented may be a little bit different based on which population and which setting that you're in.
But the question then becomes, though, is that part of the important core component? So, and diet is another area. If you remove a calorie goal and you just focus on specific eating behaviors, will it have the same outcome? So we, so in the field of translation, knowing that we have to make those modifications, do we know which modifications actually will still hold the outcome as you transition it from, to different settings, different populations, different providers, etc.?
No. I mean, I think if we did, then I think that we'd have the best intervention for every single culture, for every single place, for every, and we don't.
But I guess then that brings to my mind, like, then what do we mean when we say evidence-based? So if my program is evidence-based, but I've translated it, what does that really mean?
So just to give you two examples from practice, I worked formerly for a manufacturing company, and we had 80% sustained participation in 13 years. We did the same health screening, health coaching, follow-up, saw amazing changes, 40% risk reduction, reductions in healthcare costs, and improvements in absenteeism, et cetera. I took the same core components to the University of Alabama. I'm not close to 80% participation. I compete with so many other things, whether it's a football game or something at the theater, or it's just there, you talk a manufacturing plant, there are two ways in and out. There's control. The University of Alabama, I think I figured out 1,000. If you have a bicycle or you walk, it might even be more. I mean, there's just a lot of things you can't control for. So I think in many ways, the core components, or at least what we know research is telling us that works, may look and map very differently in each of the environments. And it goes back to, what is your culture? What does it support? And so now I have to communicate 10 to 12 ways, whereas I used to communicate 2. So it's just very different. So some of the other additional elements, I think, have to be enhanced or modified.
You asked the question, what does evidence-based mean? From a research perspective, in terms of when we look at, evidence-based research, in terms of how the CDC reviews those evidence-based practices, typically how they review those is looking at across sectors and using similar, again, constructs and how those constructs are applied. So for example, when the CDC released their evidence-based research on the effect of physical activity and cognition, or does it affect how children learn, et cetera, there were very different modalities that were used. There were very different theories that were used. But overall, their conclusion over all of that research and all the modalities and all the theories, there were some positive effects, there were some no effects, but there were no detrimental effects. And I think that that to me is evidence-based, in that across the sectors or across different activities, that you're able to see similar results in different situations. And I think, to me, evidence-based and core concepts are two totally different factors. It would be evidence-based if you're able to go through different settings and in different environments, but no one intervention is going to be effective in all those different settings or environments. I don't foresee that as possible.
Hi, it's me again. I'm Delia West, by the way, from the University of South Carolina. And I have a question for Dr. Wadsworth. I hope I said your name right.
That's great.
And so you talked about 3 different classes of texts that you sent out. Motivational, mean, and supportive, or something. I'm trying to
Gentle
visualize the middle one.
encouragement.
Gentle
Nudge.
encouragement.
Nudge 'em a little bit.
Nudging. And I'm wondering whether or not you were able to see any kind of differential response in terms of engagement or behavioral response to the different, that would help guide us in knowing, because we talk about messaging, but we really don't have an evidence base to help us frame that's an emerging area. And what are your contributions to help us know what kind of texts we ought to be sending folks?
So that's what we're working on right now. That's always the worst answer, right? I can't tell you right now, but no, seriously, that's what we're working on, is that individuals are wearing accelerometers, and first they tailor their approach. They tell us what they want. So they rate those. We give them a survey of about 30 different text messages, and they rate those as, this would motivate me to exercise, I agree, I disagree, neutral. And they rate those. So we have a rating of what they feel would be their best. And then they wear an accelerometer, and then so we're able to look at a dose response in terms of, you get the text message at noon, what did you do in the next minute, 10 minutes, 20 minutes, an hour in terms of those messages. And so we're really looking at what their perception of what they want is compared to what their actually behavior is that they do. I will say people are very definitive about the voice of authority and whether they like it or they don't. The other two, they're kind of okay with, but based on what I've seen, they're pretty definitive. And usually speaking, if the message is something they can do right then, like stop and do 10 push-ups or stop and do 20 squats, typically what we see is that we do see, and that's a little harder to measure with accelerometer than, say, a dose, but we do see a change in that behavior within about 10 minutes. Now, that's pretty much about all I can tell you. I can't say over time if that decreases after they've had, I get my text messages at week 12, am I still doing that? I don't know. I can't answer that.
And so that's really interesting. Do they do it when you do it with a non-tailored message? You don't see the same spike in the next 10 minutes? Does tailoring really make a difference?
Well, the literature would tell you that tailoring does make a difference. I don't know. I can't really answer it, because they do randomly get other text as well. So even if their bottom preference, the only thing we don't send them, if it's very clear they don't like the voice of authority, we do not send them those style of texts, because it actually may curb their behavior in the other direction. If you don't want the drop the donut, you know what I mean? That's not something that encourages you. Then that's not good for us to send that to you. But I would say that yes, tailoring is important for behavior change, and that's what other interventions have shown, particularly with these adapted-based interventions. So based on previous literature, I would say yes, tailoring is important.
We're trying to revitalize the wellness on campus, and one of the things, the big roadblocks that we're seeing is that maybe the School of Education has some of the things that they're doing, pharmacy has something, and there's things being done all across campus. And we need to centralize that, obviously, but no one wants to give up the reins of their own thing. So what are some of the strategies that you guys have used to help centralize it, yet them still feel connected in that?
Which university are you with?
Ole Miss.
Okay. So we had a program in the 1980s called Healthy Tides, led by the chair of human, health education at the time, who was also actually running the Alabama Power program, which was it was excellent. It was marginally funded. It was run by students. No one in senior administration really knew about it, viewed it, and so when after a couple of years funding was reduced, so was the program. So prior to my arriving, there was a committee of about 24 individuals representing everywhere from the faculty senate to faculty who have health-related backgrounds, staff, grounds, facilities, financial affairs, payroll, benefits. I mean, it was a very comprehensive. And they met, and a couple individuals there had the recall of what happened, and so they very quickly wrote a white paper. It took about 18 months of collaborative kind of connecting. They benchmarked, they looked at best practices, they looked at what failed in a lot of these university-based programs, and they came up with kind of their formula. Number one, we will hire a director, and that director will need to approach this in a collaborative manner. Number two, it will report to the provost. Number three, it will have a faculty appointment so that if something were to happen, there would at least be, they felt like a little more permanence in that position. Number four, they needed to not necessarily do publications, research, and teaching, but hopefully that would be part of the opportunity to do so. So I think launching it from, and what we're seeing at Oklahoma State, Susie Harrington is the Chief Wellness Officer. She reports directly to the President. We also have Dr. Bernadette Melnick at Ohio State, who is a Chief Wellness Officer. She's also the Dean of Nursing. So we're starting to see variations, but Louisville now, Patricia Benson reports to the President's office. So that's part of the lift. I think you've got to have, as I was sharing, the elements of engagement. It has to start with that leadership. And then you have to have funding. So LaVon Palma Davis is with the University of Michigan, and she's the Executive Director of Health and Wellbeing Services. They also have a Chief Medical Officer, so you're starting to see physicians come in as the Chief Medical Officer. She works collaboratively with Bob Winfield. But they, again, are positioned and they're funded. And it's long-term funding. It's not a 1 year, it's a 5 year. And actually, I think they have a 10-year strategic plan that they're just coming on. So I think those elements all coming together would be helpful. Perhaps the SEC can host a health and wellness, event, and we can rotate where that's held. But I think it's that conversation that starts and involving our senior administration too.
What are you all doing for healthy lifestyles for the student population?
We have a variety of programs that we do for the students. Of course, we have research efforts that we examine physical activity behavior, but I think one of our biggest partnerships has been with the campus recreation, and actually we have what's called Active Auburn, and it's a physical activity class they enroll in, and they have an academic component that's delivered from our unit, but then they actually go to the rec center, and the rec center actually logs whether they've been physically active and how physically active they've been by going to group fitness classes or logging in. And so that's kind of their initiate. So we have a freshman fit in which that's their first initiation into it, and then they can move on to the Active Auburn part.
What about the other components of healthy lifestyle? What about the other components of healthy lifestyle besides just physical activity?
Well, typically what I do is either physical activity or weight management. So if in those regards, so typically if it doesn't have to do with sleep, stress, or healthy eating or physical activity, then I don't do the STDs and the alcohol prevention and that's a central office on campus that's in charge of student wellness and mitigating those programs that are about cross campus. And for our university, the biggest 3 issues that they're dealing with are STDs, nutrition and physical activity, and then sexual health. So those are their 3 targeted approaches on campus.
We have some really cool things that have been around for over 20 years. So our Student Health Promotion and Wellness is actually part of Student Health Center and Student Affairs. But they have, I think they actually, is anyone from Florida, the University of Florida? They have this really cool thing called the Health Hut. And so every day they're on a different part of campus. And what they do is they obviously have a topic. And so the topic may be sexual health, it may be healthy eating, but they give out whatever. It's very health promoting and awareness campaigns as well. They also distribute flu shots during the year. So there's different things, but that's a really, really cool. They also have these strategic health teams. They involve faculty, staff, and students. And so each area, whether it's alcohol or if it's tobacco, if it's sexual health, if it's nutrition, if it's eating disorders as part of that, they have different organization or different kind of task force that look at opportunities. And so they'll host different events based on whatever that strategic team decides to work on. And then we have registered dietitians available and other, again, services. But they've been doing a lot at the university for a long time for our students. It was just that they noted that they weren't doing as much for the faculty and staff. So that was our movement as well.
And at the University of Mississippi, we have a few pocketed, I think, health resources for students. Our alcohol and drug and sexual health department is within student health. Health Department of Health Promotion is within the student health. In the Department of Nutrition, in which I'm housed, we have a nutrition clinic where students can come for individual nutrition counseling. And so we have a certified diabetes educator. We have people who work in weight management. At disordered eating, nutrition counseling is available. And then through a grant that Jay Garner, who's sitting in the corner, and a professor in our department got through Blue Cross Blue Shield, we started anew this year on campus and a health promotion program, so a more comprehensive program. We've got campus rec activities, fitness facilities, a bike program where people can rent bicycles for $25 a semester, and so to promote, mainly because we don't have enough parking, but also to promote some physical activity. And so we have a lot of pockets of things, and I think that was part of Jay's kind of question is how do we put all these pieces and parts together to have a more comprehensive program? And I think that's where we strategically, I think, need to start focus with our students and our faculty staff. But
I think the service learning is a real key opportunity that we're seeing too. There's also a group called Project Health, and there are ambassadors of health that are actually, they have to interview and be selected, and they can be involved in kind of peer education, which is really cool. And then we have our second campus recreation center. So in addition to our 200,000 square foot recreation center, we introduced a new one, 100,000 square foot, that's very conveniently placed within the student housing. And so that is a significant opportunity for students to really be engaged. And then again, to provide campaigns and awareness. And then of course the services of student counseling are always available. I think campuses just have rich and wonderful. It's just trying to reach, I don't know about tobacco, but that's something too that is essential and critical, I think, for campuses to do as much as they can around tobacco control.
our freshmen are required to take a course, EDHE 105, and it touches on a variety of those health-related topics. And it also includes a section on budgeting and how to make your money last and those types of things. So it has a nutrition, fitness component, stress management, study skills, STD, and it's required for all freshman students.
And one more, kind of returning back to your question, is when you're looking at some of the universities and how they're actually getting funding, they're looking at not only faculty, staff, and family engagement. It's faculty, staff, student, and family engagement. And then they are establishing the healthy community initiatives launching from the universities. So I think there are perhaps are some of the key opportunities of that whole coordinated, integrated approach to health. Whether it's an 18-year-old employee or a 22-year-old student. I mean, our population is very similar. There may be some very specific differences based on the age bands, but overall, I mean, we're talking, individuals between 18 and, well into their 70s. So I think there are opportunities to really leverage if you already have existing student health resources, which I believe most do.
And this question is for your work or other research that's been done in the area. So one of the nice things about worksite wellness is that you can tackle behavior change from lots of different angles. So it can be more incentive focused, it can be more environmental focused, it can be more traditional groups or individual counseling. So with all those different perspectives, is there a sense about what employers, because there are pluses and minuses to sort of putting each of those in place, that employers feel more comfortable with, or that employees may feel more comfortable with, or do you feel like that it's just unique for each setting?
For most of the work sites that I work with, they're resistant to policy changes. We are in Alabama, and politically it's a very Republican-based state. People want free choice. So policy-based changes are very difficult to do. They still do them. For example, we now have a smoke-free campus. It went from you can only smoke outdoors till you can only smoke to these areas till there's no smoking allowed on campus, period. And so, that gives an example of something that can be phased in. But typically, they want it to come from the employees. And I will say I find that's what works best. It is when we look at the ecological model, a bottom-up approach works a little bit better for the work sites that I've worked in. But I do think, depending on how the new healthcare comes into play, with maybe a little bit more focus on prevention, people may be looking for a little bit more policies that are going to be incorporated into work sites in terms of healthcare providers, et cetera. I mean, we've seen that over the years in terms of transition, particularly with tobacco. I think, physical activity and nutrition's a little bit harder to manage. Either you smoke or you don't. It's, black and white. Exercise nutrition is really not like that. So from a BMI or an obesity perspective, it may be a little bit more difficult. I do know for our insurance at Auburn University, if you're over a 35 BMI, you do have to show that you are doing intervention strategies, or you will pay more in terms of your insurance. What those strategies are very loosely defined. But that is a policy that's been implemented within the past year, and the people aren't happy about it. Whether you're normal weight or obese, there was a lot of flack that went along with implementing that policy.
So a couple of things. In my former work, I spent 13 years and helped about 300 individuals quit tobacco through educational outreach efforts. When they became tobacco-free, 300 people quit that year. So when you change the environment, you very quickly change behavior. And I think that's very important to know. So it depends on what you're trying to do. At the University of Alabama, we elected to do a voluntary participation in our wellness screening and health coaching. And the reason we did that is the approach wanted to be very much the positive reinforcement. You participate, here's your incentive as well. What I've noted among my colleagues who have 3 times the participation, they may be close to 70, 80, or 90%, is that they have an incentive which may be larger, $200, $300, $400 to do that. But their change and improvement is like 1 or 2% of the population. So I'd rather see a lower percent with more significant change than a higher because you get the responses of that kickback. And I think we have to be very careful because when you look at what health conditions cost the most, the number one is depression. So if you're going to really look at individuals that you want to connect and see who's costing more, it's depression, it's high cholesterol, it's diabetes, it's, you know, and then of course it's obesity and it's physical activity. So I think one of the things I continue to caution our faculty staff benefits committee is once you go down that path of charging tobacco users and then those who are obese and the next is those who have depression or those who have diabetes, when does it stop? And so I think it's very important, which is how we clustered the health and put them in different categories, and they all have an alternate standard. So every single participant could be in Crimson through an alternate standard. And that is exciting for participants to know. I can set goals, but I also have alternates. So if I can't get my BMI to this, if I participate in a weight loss program, I'm still eligible. And that's, to me, that's a beautiful, positive way of approaching health.
I'll just make a couple of comments. At GE, they went to a smoke-free campus completely, but they provided free smoking cessation support for those individuals. And so that I heard very little kickback from that. Again, I'm not there all the time, but the employees, because they offered that support to them and how to do that, I think it was a little taken a little bit easier. The change in the vending machines, you know, part of that was actually employee driven. And so if you walk in there now, there are no Cheetos and Lay's chips and things. There's only baked chips. We actually got a vending machine that is refrigerated so it can have turkey sandwiches and some less long-lasting shelf life items. So I think some of those kind of policy changes were because they were offered support during that transition, were actually accepted pretty well. On our Ole Miss campus, there's still, we're a smoke-free campus, but there's still pockets of smoking in little pieces and parts. So I think we're still working to get there. I think we're officially smoke-free, but people smoke.
Well, that's like we're alcohol-free except on game day Saturdays. I mean, you know. Guess that doesn't count.
Are there other questions?
I just want to follow with the vending machine. Hi, I'm Sohyun Park from CDC. For after changing the vending machine options, the sales change. Do you have sales data on that?
Actually, I do have, that's one number associated or dollar associated data point I do have. And actually, they saw an increase in sales and an increase in the number of people that were staying at the plant during their 30-minute lunch break versus going to those 3 fast food restaurants which were in driving distance for their 30 minutes. So that actually was a very positive. It's costly to transition those vending machines, and you know, the company elected to just purchase those machines versus go through a company, and so that it took a little time to do that, but actually have seen an increase in the sales from those vending machines. And the company supplements the cost of those products to keep them from being, you know, $7 for a turkey sandwich. So they're actually pretty reasonable. I think the most expensive item in there is $2.25, and it's a roast beef with Swiss cheese. You know, so I think that the company made that commitment that if the employees will do this, then we will supplement the cost of those items, because cheese, crackers, and Cheetos are pretty cheap, you know, to put in a vending machine. And there's no soft drinks on campus, so if people want their soft drinks, they have to bring those as well. So the vending machines have not even diet drinks. They have water, they do have sports drinks, and they have some flavored waters and some juices.
I don't know if any of you have done this, but something that's been done in the research, and I think we'd love to do it, is food labels are fine. You know how many calories, and it may actually, for those that read it, might actually influence their behavior and change what they consume. But when you connect it to the minutes of exercise, so I don't know if you all have done that, or is that something a possibility? That's very cool. So if you're thinking about again, we have a very large Starbucks on campus, and so if it's one of those with a lot of extra calories in it, and it's 600 calories, you can say, gosh, this is equal to 6 miles of walking or an hour and a half of walking. It just gives a very different perspective. So we have not yet introduced that, but I do think that's kind of a cool concept, going back to, again, we can't always predict behavior, but at least we can provide some insider cues to see if those who are interested can explore and make some different changes.
My question is for each of you, from your perspective and in the settings that you do workplace wellness, what do you think the most compelling research questions are for we've got some students here. One of the other breakout sessions, somebody closed with this, and I thought it was very interesting about, from given your perspectives, what kind of guidance, if you were directing students in particular, or some seasoned professionals who might be interested in what are from the field, what are the most pressing research questions that we need to answer right now?
I'll go first. I think the research question that I'm most interested in answering, and not just necessarily from a worksite perspective, is really, what's it going to take to have lasting change? And I think we can address that from multiple domains and in addressing multiple different issues. You know, for me, my main goal in life is so everyone can exercise and hold hands and be happy, you know, whatever that is. But I want individuals to experience, whether it's just getting 10,000 steps or it's actually engaging in, you know, a vigorous exercise such as Zumba or whatever they enjoy. And not necessarily for the benefit of weight, but for the other benefits that are associated with exercise. And so for me, what I really want to answer is, what can we do to affect that lasting change? And I think that you could base a whole career off of that question, such as I have, because I don't know the answer. I can tell you little pockets of what might be the best thing for that, but as a whole, I just don't think we have the answer to that question. And the problem with behavior is there's so many variables that come into behavior. You know, yesterday we listened to a whole genetics and physiology, and now we've got the environment and the personal and the social, and you're trying to fall all these together. And we spend a lot of time thinking about which of those is the most important. And I'm not necessarily sure that one's more important than the other. The better question is, how can we merge all those together to really look at lasting change? And I think that's a difficult question to answer, but for me, that's the one that needs to be answered. You better get on it.
Yeah. For me, there are 4. One is organizations' culture completely impacts the health and well-being of their whoever is present, if it's faculty, staff, students as well. So how do you define culture? How can you weave health into the fabric of the culture? And what does that really look like, knowing it looks different in every single organization? Number 2 is, what are we really measuring? You know, is it, again, we used to measure this return of investment based on you improve health, and we looked at the healthcare cost, but we're really looking at value. And so I just came back from a conference last week presenting on employee engagement around, when you improve your health, your performance ratings improved. You actually were a better employee, more engaged, your absenteeism reduced. So it's really, what's the value of this investment? And I think we're going to hear a lot more about that and how to answer it, which goes into my 3rd one, which is the methodology. There is not consistent methodology of how to compare a program success to the next program success. And how individuals are defining success looks very different. Some are controlling or matching, you know, participants and non. It's just, there's great variability, and I think as an industry we have to do that. And the 4th, I think, driving to students is, what are the skills, the knowledge, the education, the training, the skills that they need to have to really move into this field, because we have more and more students exploring and wanting to. But I think right now we don't have a specifically designed curriculum, and I'd like to, I think that's my question, is how can we build that for the students so when they come out, they are being matched with employers who can really take their skill set and move them into a position. So I see that as an opportunity as well.
And I think I would agree with both of them. Those are all great questions, particularly the methodology piece. It's hard when you're comparing your program to other published data. There's no consistency in how people are measuring those types of things. But I think, how do we help people to individually overcome their perceived barriers to making healthy choices? And I think as an exercise physiologist and a dietitian, I'm a member of 2 professional groups, and I think we sometimes, from those groups and other agencies that work with them, we publish to our citizens these standards by which we should all be compared to say you've got to get this much physical activity, you need to eat this many fruits and vegetables. And for people who are doing none of that, I think it's very overwhelming. And so you go, well, if I don't even eat a vegetable now, am I going to be able to get 9 servings of fruits and vegetables? So I think we sometimes are way over recommending what is realistic for the population. And so I think if we could just back up a little bit and have some evidence-based maybe research on how do we help people to overcome their own barriers, as opposed to being those health professionals that say do this, 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 and this, and you're going to be healthy. How do we just help them adopt those changes gradually where they're more palatable to stick with, as opposed to these programs that stop and start, or this, I'm on a diet, but that means I'm off a diet eventually. Or so I think how do we do that? And I think the research, while we have a lot of knowledge in a lot of very specific areas, we haven't put it all together to reach a multitude of populations.
Any final question?
I have a closing comment, and it actually expands on what Melinda's saying. B.J. Fogg is a researcher out of Stanford who really looks at health behavior and changes. And one of the things he's really introduced, and I think I'm hearing more and more about this, is it's not enough to say I'm going to start exercising. You have to break it down into the tiny, tiny steps. And at the university, when we talked about introducing and engaging, gosh, we have well over 900 employees in the Crimson Couch to 5K 9-week training program. One of our ambassadors said, somebody asked me, what music do you listen to? Because before she was able to actually prepare and get ready to exercise, she needed to know what music to put on her device so she could listen. And the point is, what he's saying is, don't think that I need to exercise or I'm going to exercise 3 days a week is really where you need to start. You need to start by asking them, do you have a pair of tennis shoes? Or do you have, do you have clothes that fit you to actually work out in? These are, if you think about what you have thought about doing in terms of health improving and you haven't, it probably is because you didn't start with the first tiny step, which was planning it or finding someone who you could work out with, or, and again, going back to the sustain, how do you sustain it? But I think there's a lot of importance, and I think we're going to hear more about these tiny habits, and I think it's really cool research too.
Let's go ahead and thank our speakers for sharing their thoughts and their work with us.